Today we will discuss ascites. In most healthy individuals, there's very little free intraperitoneal fluid. Clinical research has shown that some women may have about 20 milliliters during the menstrual cycle. Ascites is the pathological accumulation of fluid within the peritoneal cavity. It is the most common complication of cirrhosis and occurs in about 50% of patients with decompensated cirrhosis in 10 years. The development of ascites denotes the transition from compensated to decompensated cirrhosis. Pathophysiology. Under normal circumstances, the amount of peritoneal fluid depends on a balance between plasma flowing into and out of the blood and lymphatic vessels. It is only when this balance has been disrupted does ascites form. This imbalance may be due to increased capillary permeability, increased venous pressure, decreased protein or oncotic pressure, or increased lymphatic obstruction. Etiology. Ascites is one of the most frequent complications of cirrhosis and portal hypertension. Up to 50% of cirrhotic patients will develop ascites within a 10-year follow-up period. Based on clinical study reports, hepatic cirrhosis accounts for up to 85% of cases of ascites, and malignancies account for approximately 10%. Other than cirrhosis, hepatic causes of ascites include hepatic venous outflow obstruction, like hepatic vein obstruction, Budd-Chiari syndrome, and veno-occlusive disease, portal vein occlusion, inferior vena cava obstruction, hepatic cancer. The other types of ascites are categorized as cardiogenic, nephrogenic, infectious, and miscellaneous. Cardiogenic causes include congestive cardiac failure and constrictive pericarditis. Nephrogenic ascites is due to nephrotic syndrome. Infectious ascites may be caused by tuberculous peritonitis, spontaneous bacterial peritonitis, fungal infection, parasite infection, and chlamydia infection. Malignant ascites may be due to ovarian cancer, cervix cancer, endometrial cancer, breast cancer, esophageal cancer, gastric cancer, colorectal cancer, lung cancer, pancreatic cancer, hepatobiliary cancer, and primary peritoneal cancer. Miscellaneous causes include chylous ascites, pancreatic ascites, bile ascites, ovarian disease like Meigs syndrome, struma ovary, ovarian hyperstimulation, systemic lupus erythematosus, Whipple's disease, sarcoidosis. History and physical. Patients typically report progressive abdominal distension that may be painless or associated with abdominal discomfort, weight gain, early satiety, shortness of breath, and dyspnea resulting from fluid accumulation and increased abdominal pressure. Symptoms such as fever, abdominal tenderness, and confusion can be seen in spontaneous bacterial peritonitis. Patients with malignant ascites can have symptoms related to malignancy, which may include weight loss. On the other hand, patients with ascites due to heart failure may report dyspnea, orthopnea, and peripheral edema. Those with chylous ascites report diarrhea, steatorrhea, malnutrition, edema, nausea, enlarged lymph nodes, early satiety, fevers, and night sweats. Patients with ascites typically will have flank dullness on examination, shifting dullness, a fluid wave, evidence of pleural effusions, and findings related to the underlying cause of ascites, such as stigmata of cirrhosis like spider angioma, palmar erythema, and abdominal wall collaterals. Jaundice, muscle wasting, gynecomastia, and leukoplakia are present in patients with advanced liver disease. An umbilical nodule that is not bowel or omental, such as a Sister Mary Joseph nodule, provides evidence for cancer as the cause of ascites. In heart failure, physical examination findings may include jugular venous distension, pulmonary congestion, or peripheral edema. Evaluation: diagnostic abdominal paracentesis with the appropriate ascitic fluid analysis is probably the most rapid and cost-effective method of diagnosing the cause of ascites. The initial tests that should be performed on the ascitic fluid include a blood cell count with both the total nucleated cell count and polymorphonuclear neutrophils, and a bacterial culture by bedside inoculation of blood culture bottles. Ascitic fluid protein and albumin are measured simultaneously with the serum albumin level to calculate the serum ascites albumin gradient. The presence of a gradient greater or equal to 1.1 gram per deciliter predicts that the patient has portal hypertension with 97% accuracy. This is seen in cirrhosis, alcoholic hepatitis, heart failure, massive hepatic metastasis, heart failure or pericarditis, Budd-Chiari syndrome, portal vein thrombosis, and idiopathic portal fibrosis. A gradient less than 1.1 gram per deciliter indicates that the patient does not have portal hypertension and occurs in peritoneal carcinomatosis, peritoneal tuberculosis, pancreatitis, serositis, and nephrotic syndrome. Additional tests may be performed only if a specific diagnosis is suspected clinically. LDH and glucose level should be determined in suspected cases of secondary peritonitis. Other tests to consider include amylase greater than 1000 unit per liter suggests pancreatic ascites. Mycobacterial culture should be performed only if tuberculosis is strongly suspected. Other ascitic fluid indices such as lactate and pH offer little to no additional information. Chest X-ray may reveal elevated diaphragm. Ultrasound is the most sensitive test to detect ascites. It will reveal homogeneous, freely mobile collection. In the peritoneal cavity, the smallest amount of fluid is usually seen in Morrison pouch. CT scan can also be used to detect ascites and may also help determine for presence of any masses. Management. Appropriate treatment of ascites depends on the cause of fluid retention. The goals of therapy in patients with ascites are to minimize the ascitic fluid volume and decrease peripheral edema without causing intravascular volume depletion. Sodium restriction and diuretics form the basis of treatment. In cases of high albumin gradient ascites, which occurs in cirrhosis, the treatment of ascites in these patients includes abstinence from alcohol, restricting dietary sodium, and treating with diuretics. Patients with a treatable liver condition such as autoimmune hepatitis, chronic hepatitis B with reactivation, hemochromatosis, or Wilson's disease should receive specific therapy for these diseases. Occasionally, cirrhosis due to causes other than alcohol or hepatitis B is reversible. However, these diseases are usually less reversible than in alcoholic liver disease, and by the time ascites is present, these patients may be better candidates for liver transplantation than for protracted medical therapy. Low albumin gradient ascites commonly occurs in non-ovarian peritoneal carcinomatosis. These patients often benefit from an outpatient therapeutic paracentesis. Patients with ovarian malignancy may benefit from surgical debulking and chemotherapy. Tubercular peritonitis is treated with antituberculous medication. Pancreatic ascites and postoperative lymphatic leak from a distal splenorenal shunt or radical lymphadenectomy may resolve spontaneously. Chlamydia peritonitis is cured with antibiotics using doxycycline, and ascites caused by lupus serositis may respond to glucocorticoids. For years, many types of active and passive pumps have been developed, but none works reliably. They are prone to obstruction, mechanical failure, and leaks. Therapeutic paracentesis is often done for symptom relief or in patients with tense ascites. Supplements of albumin should be administered at the same time to prevent hypotension. Terlipressin is recommended instead of albumin if available. Transjugular intrahepatic portosystemic shunt is an effective treatment for patients who do not respond to diuretics.